So, a really big welcome to everyone who's joining us today. Keep your fingers crossed for us that the technology holds out. My name is Steph Thompson and I work with My Home Life England. I'm going to start by doing a bit of housekeeping and tell you about the structure for today. As there are so many people joining us, which is great, and I'm watching the numbers go up as I speak, we don't have time to ask everyone to introduce themselves. And while the main content of the webinar is taking place, unfortunately, you won't be able to ask questions or comment, but there will be a chance for both at the end. Just so you know, we are recording today. With a snappy title, Developing and Commissioning Quality in Care Homes During Times of Uncertainty. But our focus is how quality of life in care homes has developed over the past 15 years or so, during which there have been many uncertain times, no more so than in the last year. Importantly, we want to focus on a couple of themes. Quality of life in care homes is dependent on many things and many people. And co-creating research, policy and commissioning approaches with people who live, die, work in and visit care homes supports quality improvement. Whilst we will be sharing something about My Home Life England, particularly in part 1, we want to shine a light on others who are constantly thinking about this complex area. Our aim is by the end of this webinar, you will have heard at least one idea or picked up one top tip to help you in the work that you do. This webinar has 5 parts. So part 1, 15 years ago, what did we know about quality of life in care homes and some of the work that we did to help develop an evidence base? Part 2 is a tiny sample of some of the positive ideas and changes that have happened from 2006 to 2019. The impact of the pandemic is part 3, how thinking and ideas have developed quickly. And then looking forwards, what can we imagine? And then finally, a question and answer and comment session. We could have invited so many people to contribute to today, including many of you who are joining us on this webinar. And we know the stories and ideas you're about to hear are not unique, but they give a glimpse into some of the amazing work that people do, with a mixture of slides, information, and some great videos. We'll be joined in person for the last section by Deborah Sturdy, and as many of the video heads as possible will be available at the end to answer questions as well. But we'd like to start with a quick anonymous poll. So this poll will pop up on your screen now. If it's okay, when the place that you work comes up on screen, please could you tick the one that most represents you? Can we have the results now, please, Lucy? Oh. That's a great variety of people. Now I'd like to introduce you to Tom Owen for part 1. Tom is the director of My Home Life England. Tom.
Thank you, Steph, and good morning, everybody. And it's a real shame that we can't see you all, see your faces and have a proper two-way conversation. But we've worked really hard to pack this webinar with lovely stuff. And so, we hope it's really helpful to you. So as Steph has said, I'm going to talk a little bit about the work that has been carried out 15 years ago around quality in care homes that helped launch the My Home Life programme. Back then, I think negativity towards care homes across health and social care system, and I suppose across the public at large, was very apparent. There seemed to be a constant drip feed of national and local reports that wagged a critical finger at the care home practitioner. And these negative communications were met by a mixed response of public outrage and indifference. Some of the so-called myths and dragons that we heard during this period of time are included in this slide. There was a perception that care homes were only interested in profit, embroiled in poor practice, abuse and scandals, poorly staffed and lacking expertise, sometimes run by people with no commitment or values, and generally in decline and with a reduced relevance to us all. And we know that from talking to care homes at that time, that such negativity exacerbated poor morale in care homes. It reduced their capacity to recruit great staff and to deliver quality of life. So for me, it felt that actually the coverage of these damning reports was themselves reducing care homes' ability to deliver quality. With this in mind, Help the Aged, along with National Care Forum and a small group of care home leaders, took it upon themselves to commission Professor Julianne Mayer at City University, along with 60 academic researchers and care home leaders, to look at what worked well in care homes. So rather than looking at poor practices, what does actually good practice look like in care homes for older people, their families and staff? The review also focused not just on quality of care, but quality of life, acknowledging that care homes are about living, not just passively receiving care. And this is the next slide shows the cover of the original report that was launched at a London conference in summer of 2006, a long time ago. So since then, we've tried to keep the evidence base updated. We've learned from attempts to deliver quality of life, working alongside care homes, and learning and sharing all of that new evidence. So what did the review of evidence tell us about quality? Well, a bit of a whistle-stop tour for you here. And sorry for the small writing. So basically we found that the evidence base was found to cluster around 8 themes. And the first 3 themes are described as personalization themes, because they're all about how care homes support residents, relatives and staff to have voice, choice and control. They're about how care homes respond to what matters to the individual, what helps them feel connected to others in the home and those within the wider community, supporting them to be involved in their own care planning and the running of their home. The second set of themes are about how we support residents and relatives and staff to navigate the journey into the care home, from their initial visit and assessment to the end of their lives, responding to their ever-changing needs and circumstances during their time in the home. Then there are the transformation themes. These are more general themes to support leaders to deliver a culture of practice that helps staff to feel competent and confident, delivering a reflective culture of engagement, responsiveness, and dispersed leadership. Okay, the next slide gives us a sense of what is the underpinning principle that sits at the heart of good practice. Relationship-centered care. This is about the need to create a culture where relationships and deep connections are developed between residents, relatives, and staff, knowing that through these relationships, we can help each individual resident, each member of staff, each family member to experience a sense of security, of safety, of continuity, that help them to feel significant, that they belong, and a sense of achievement and purpose. Our work is also founded upon the concept of appreciative inquiry, so helping care homes to reflect on the great work that they're doing and exploring with them how they can make it even better. And finally, a few years later, an additional framework called Caring Conversations was introduced by a colleague, Professor Belinda Dewar, who is the lead for My Home Life Scotland. And this framework has been adopted to support care homes take forward quality improvements and leadership development. So, a race through the evidence base for My Home Life. And there's loads more information on our website if you fancy having a little look. I think the crucial aspect of our work to date has been that we've worked alongside care home managers and senior teams who hold that pivotal role in leading the culture in the care home, and so can take forward some of the evidence-based framework. And now a little video of someone called Alison Wood, who was a member of our original advisory group and a resident herself, though sadly no longer alive. And she says a little bit more about that role of the manager. It's coming. Oh, yes.
Managers, I think, are vital to the successful running of any residential establishment. Everybody says, oh, don't form too close relationships with staff. But if you and staff can't find each other in some kind of level, I think that doesn't make for a good home. People who are responsible for organizing the homes don't always take on that they are taking on a person's lifetime. Everybody has to have some idea of what that person really is, who they really are. inviting people to have a say about their lives and a say about how the places where they have chosen to live or have to live is run, all makes them still feel human. And existence becomes a little bit less low down the scale. You still feel that you are contributing something to the common life of where you are. Because some of the residents, like the staff, have very considerable characters. They've lived very considerable, interesting lives. You're the sum of all the things that have happened to you in your life, which have brought you to who you are now.
There to Alison. I'm not sure whether we had some troubles with the videos there. It might be that when you're listening to it, you might want to put the volume up, and we'll see. Hopefully that will be better in the next videos. But for now, let's go back to Steph.
The videos will work. The videos will work. That's the phrase we've all heard over the last year. You're on mute. So it's my job to move us into part 2. Since my home life started, there have been huge amounts of changes in structure, systems, policy and ideas that have directly impact on how people using care services and people commissioning them have thought about what quality means within a care home. Wherever you live in the country, the care and support you receive will be different. This is as true about our experience in the NHS as it is in social care. Whilst research and evidence might be used to support consistency of approach and policy might be written to apply across England, there will always be local variation, interpretation and difference. In social care and in care homes, there are the additional complexities of variation being directly linked to a care home provider's vision, mission, values and operating model, as well as variations in funding structures, skills mix, areas of local expertise, and crucially, relationships between care homes and the wider health and social care community. However, one thing that is consistent across the country is that over the last 15 years, people who live in care homes now have more needs and often a wider range of complex health needs than in the early 2000s. So, our collective approach to quality has needed to develop in response to this, as well as to many other things. Social media, research, economics, politics, and policy have all influenced our perspective and created continuous change and uncertainty for care homes. This next slide has a small selection of some of the legal, policy, or structural changes that have had a direct impact on how quality of life has been measured, described, or legislated for in relation to people who live, work, dine, and visit care homes. You may have a different view about the significance of this list. We might have missed some. You think that there might be others that have had more impact. Whatever your personal perspective, things have changed a lot over the last 15 years, including the implementation of the Mental Capacity Act, the establishment of the Care Quality Commission, a much stronger focus on support and research for people with dementia and their families, the Francis Report into Mid-Staffordshire, the changing role of the National Institute for Health and Care Excellence as it now is, and the development of clinical commissioning groups. I won't go on. There are so many people and organisations involved in defining 2 care homes or assuring themselves about quality in care homes. It can be confusing and conflicting at times. So in this next section, we've invited people to tell us how they have thought about quality of life for people who live, die, work in and visit care homes in the context of some of these changes. Tom, over to you.
Thank you, Steph, and welcome to anyone who's just joined this My Home Life webinar. So now more about partnership working with care homes. And as you know, quality in care homes relies not only on relationships within the care home, but also between the home and the wider health and social care system and the wider community. And My Home Life England has seen how top-down approaches to working with care homes can really reinforce a passive sector that lacks confidence. Where the system determines what care homes do and how they do it, it can result in homes feeling disempowered, overburdened, undervalued rather than nurtured and supported to lead their own agenda for quality improvement. However, in recent years, we have witnessed attempts to shift this. An evaluation of our work within Essex with Essex County Council some years ago by Joseph Rowntree Foundation showed how the quality team within the local authority tried to change its approach from one of compliance and quality monitoring to developing a more coaching and enabling role. And the evaluators noticed how, because of that, the care homes began to trust the quality team more. And they started to be able to feel that they could share some of their challenges. And that itself helped them to prevent problems from escalating and becoming much, much worse. We've also noticed that where care home managers are supported to develop their professional confidence, their leadership, then they're more able to work effectively with others in the system. And now at this point, I'm going to go over to Johnny Kevill from Liverpool City Council, who's with us, but here's a video from him, who shares his experience.
Hi Tom, hi Steph, it's Johnny Kevill from Liverpool City Council. I've worked for the council here about 20 years, mainly across the performance, quality and information sections. You've asked me to answer a couple of questions today, which I'm very happy to do. Your questions asked how I and colleagues at Liverpool City Council had worked with partners and others to support quality in care homes, and then how have we involved the homes themselves in this process. For a number of years we've had issues around the levels of quality in the care system and the care homes in Liverpool. In some parts we were an outlier according to CQC ratings. A consistent issue that came up was the leadership within the care homes. Most of the issues identified could be traced back to the leadership capacity in the homes themselves. We took the decision to address this head on. We work with partners across the care system, health partners, CQC and others. The first task was to develop a much more constructive partnership with providers and move away from the old adversarial approach. Secondly, we needed to corral all resources we had aimed at supporting the care homes into a cogent strategy. And thirdly, we needed to support the sector to modernise and take full advantage of the innovation and developments that are out there to drive improvement. The key part of this improvement drive was to support the leadership of the homes. The managers and deputies needed to feel that they had the support of the system, and as well as delivering training, information and advice, we could take their concerns seriously and make changes in our systems to help them. Key issues that come up again and again were our payment system, clinical support, equipment services and hospital discharge. We were able to get senior people responsible for decision making into care home meetings with managers and discuss and solve these issues. This was extremely positive for both sides, a constructive conversation where each party could see and understand the pressures that certain decisions or processes led to. I was introduced to My Home Life by one of our partner agencies. The approach to leadership, development and improvement in care homes chimed with our project. Tom and the team came to a couple of our care home forums and sparked interest. We have so far had 3 cohorts of managers through the programme and a well-established alumni in Liverpool. We're about to embark on a 4th cohort. The net result of our joint working and partnership approach has led to marked improvement in all our overall ratings. We still have a journey to travel, but the new approach, the concept of partnership and pooling of support resources has made a tremendous impact. I hope this answers your questions.
Johnny described the impact of the My Home Life England work, and actually recent evaluation from City University of London seems to reinforce some of the messages that he conveyed. It confirms that long-term professional support helps managers to gain confidence, to develop professional boundaries, to delegate more, and enhance their interpersonal skills. And according to the participants, this leads to an improved culture in the home, as staff are better supported to give of themselves to their work. A separate evaluation of the impact of the programme undertaken in northwest London also shows that the My Home Life interventions have reduced hospital admissions and conveyancing, A&E and ambulances. So, of course, we also need to recognise the huge efforts of care home providers themselves in taking forward innovative practices over the past 15 years. Improving the quality of life for people living with dementia, accounting for some 60 to 80% of people living in care homes, has been one of the areas of development. Majesticare is just one of many providers that have taken huge steps forward to make a difference. And in this next video, Lily Patrick, Thelma O'Leary, and first Tracy Doherty from Majestic Care tell us more.
Hi, my name's Tracy. I'm Deputy Manager at Vernon House Care Home. I've been here since it opened April 2017, and it's been really nice watching the journey of Vernon House. As well as myself, I started as a carer in Majestic Care, obviously see something in me. I was then promoted to a senior, and then after about 12 months, dementia lead. And now I'm fortunate to have the role of Deputy Manager, although I still oversee the care and the residents on the memory care suite. I believe that the memory care suite enables a person who has a diagnosis of dementia to remain to be in them right from the start. When we do the pre-assessment admission, we find out all the little details. You know, I like my cup of tea of a morning, and if I have it in early, then I have it in a little cup with one sugar. It's all those finer details. We find out them right from the start. So when that resident comes into Vernon House, we've got all the information. So for them, it's like stepping from one home to another home, and it just makes them feel a lot more comfortable. And then we start enabling all those things that they can do, the tasks that they complete themselves, with just that little bit of prompting or that little bit of encouragement, and just enabling them to still remain the person that they are. Jelly Drops trial with the Jelly Drops team. We had all the information and why it was started off. From the creator's grandmother, he noticed that she was low on her fluids. So we've got on board with that, and it's taken off really, really well. Our residents have really enjoyed having it, and we've watched them progress in different ways. It's exciting watching them pick the different colours, the different flavours, and we've been on board with the Jelly Drops team to almost fine line these jelly drops, so the texture and some of the taste, and we've monitored how many jelly drops they're having each day, and we've got a chart, so then we transfer that onto each week, and we've noticed an increase of probably about 10 to 15% of the hydration. And then of course, because you're drinking more, then the nutrition intake is more. You know, your mouth's got these nice flavours, and it gets you talking about things. You know, we put residents 2 to 3 to a table with the jelly drops in the middle, and it's got them talking about them. And then without them even realising it almost, they're having all this fluid intake. And it's just been absolutely marvellous. The improvement that we've seen, less falls, less UTIs. Also with the cognition, the activity and the stimulation is a lot better than we would have imagined along that path of dementia.
My name's Lily, and I'm the Creativity and Heart Coordinator for Majestic Care. What energises me about supporting the quality of life for those residents living with a dementia is when I walk onto those memory care communities and just see it full of life, full of residents doing activities, just smiles and laughter, and it is just great to see. Because why should life have to stop when somebody goes into care? It doesn't stop. It should be more fulfilled. There should be more going on, more activity, more needs met, and enhancing the different activities to meet those needs of different individuals. Yeah, it's really important to me to see those individuals flourish. This year we relaunched the Continue Bme Ethos, which has been set up to create and strengthen links between residents, staff, families and the wider local community, to create an interactive, person-centred approach to care. We do this by looking at and collating the individual's life history, life experiences, and taking time to talk with their families to find out exactly what we need to know about that individual. In building a more extensive picture, we can improve and enhance the quality of that individual's life because we're able to know their likes, their dislikes, making their time with us fulfilling and nurturing to them.
My name is Thelma O'Leary. I started here at the very beginning 4 years ago. Came in as a carer. Went on to do nurse associate. I was also senior, and now I'm activities lead. We had this one lady, and was getting her to come out to talk with other ladies. I, I knew it would be quite difficult to get her to come out because her daughter had already said that to me. So I went in, I was asking her about her hobbies when she was younger. And then she was telling me she used to do dressmaking and knitting and stuff like that. So then I got her out into little groups doing the knitting. And now she virtually runs the knitting group. She loves going to the church, so we do the church service with her. And it's something she enjoys, but I let her have a lot of input in conversation. Like, we have meetings, she talks about what she would like to do in it, and I think that's what helped her come out of herself. So just stuff like that generally with them. That's what I do with each resident. He said to me that I wouldn't be able to do like a wish type thing for her. I wouldn't be able to do it. And I said, well, go on, give it a go. What is it you want? And she used to live in China. So she said, well, I want to go back to China. And I said, well, I can't do that, but leave it with me and I'll see what I can do. So I brought China to her. With the Chinese dragon. Our family all came in and we set an area up in the bistro by the piano. And we had it looking like a Chinese restaurant. We had all the decorations. And we ordered in Chinese meal, and they had all the courses. Went outside. All the other residents in the home were either on the balconies watching, in the dining room watching. The Chinese dragon then did the dance and did the whole lot. Then went through the home to everyone else. Another lady wanted to go to Daniel O'Donnell's. She was a big fan of Daniel O'Donnell's. I did look and I did try to find if he was playing in England at that particular time or when he would be playing to see about getting tickets, because I would have took her. But he wasn't going to be playing in England. So I got in touch with him after a while, bit of stalking, and he sent her a birthday message and to herself and to all the other residents here in the home, which was lovely. And then we had all our family came in and we did like a dinner dance. So we had the food there, and then we had all the Irish music playing for her. And then in the middle of it, then Daniel then was on the screen doing the message. So she was like very teary-eyed with that.
Elma there, some really great examples of innovation, and so many thousands of different care homes are doing extraordinary work in that regard. Okay, so over the past 15 years, there's been many different quality initiatives locally and nationally, too many to cover in this webinar. But we did feel that it might be helpful to share something about the work of academic health science networks, some of whom are doing great work in supporting care home quality. This next video, recorded as a PowerPoint presentation, tells us about the work of two academic health science networks. We will hear from Cheryl Davis and Jeff Cooper at the Wessex Academic Health Science Network, and from Faye Sibley at the Health Innovation Network, which is the AHSN for South London. So over to Cheryl, Jeff, and Faye.
Hello everyone, my name's Faye Sibley. I am the Head of Healthy Ageing at the Health Innovation Network.
My name's Jeff Cooper. I'm the Programme Manager and Lead for Deterioration for Wessex Patient Safety Collaborative.
Hi, I'm Cheryl Davies, Programme Manager for Healthy Ageing at the Wessex Academic Health Science Network.
And so academic health science networks are a connection of networks, and there are 15 academic health science networks across England. The aim of the AHSNs is to try and help the spread and adoption of innovation and best practice. So AHSNs work locally, so it's really important to us that we are able to foster relationships and partnerships with our local organisations and really focus in on their local priorities. But then one of the huge advantages of the AHSN is also how we work nationally. And one of the real great things about AHSNs is the ability for us to share best practice. So when one area is doing something that's really being shown to work and drive improvement, we're able to share that through our network. So these are just a list of the national programmes and priorities. And the one that I really want to draw your attention to on that list is the patient safety priority. Patient safety collaboratives were established in 2014. And the patient safety collaboratives have established structures, processes and networks that provide opportunities to drive patient safety improvement using a quality improvement approach. There are also 15 patient safety collaboratives, and I'm now going to hand over to Jeff to tell you a bit more about some of the work they do.
So I've been asked just to quickly take you through a quality improvement project that we ran in the care sector that's become a national initiative. So the focus of the project was deterioration. Started with sepsis, became all forms of deterioration, and most recently, of course, we tackled COVID. The idea is to look for an approach that adopted the same language across the whole of the care system, starting reading backwards from the hospital. Could we identify deterioration earlier in the emergency department, in the ambulance, at the GPs, or even in care homes? The first tool that we developed with care homes, and mainly nursing care homes, was a deterioration and escalation tool that is now known as Restore 2. And that involves an approach that identified soft signs based on what's normal for a resident, used the National Early Warning Score, escalated according to the thresholds, and used a safety communication system called SBARD. So that was developed as a quality improvement project, as I say, in Hampshire with nursing care homes. But other carers in residential care homes don't use the National Early Warning Score. They don't take a physiological approach, and other areas didn't want a medical model in their care homes. So together with the residential care homes and other carers, we developed a version of Restore 2 called Restore 2 Mini, and that focused on two areas: the use of soft signs based on what's normal for that resident, and then the use of a safety critical communication tool called SBARD. This was a simpler tool and developed with people an A4 copy for filing in the residents' notes. And this was just primarily focused on using soft signs, using awareness of what's normal for a resident, and when that changes, when they display behaviours that are different from that, using the SBARD communication tool, situation, background, assessment, and recommendation plus decision. It was very important we looked at end-of-life care, so that was included as well. We then moved on to developing resources to support carers, and that included a rollout handbook. We managed to record 14 videos for Health Education England, and then 7 of those videos have been refilmed for the learning disability community. All of those resources can be accessed through a number of websites now. Most AHSNs or patient safety collaboratives have a Restore 2 or equivalent page on their website. It's been adopted by the CQC and the NHSEI guidance there. It's won a number of awards, and that's been really encouraging because the peers, the colleagues have said, this is really helpful, this works. So it's got national spread now. That's me. Thank you very much, and I'll hand you over now to Cheryl Davis.
So this slide encompasses all of the different projects relating to care homes that the Wessex Academic Health Science Network undertake. And as you can see, it's very interlinked into the patient safety offer in terms of the deterioration patient, medicines, care safety in care homes, and recent work around virtual wards with pulse oximetries. There's also a very active healthy ageing programme. There's also a digital stream to the primary care arm as part of the AHSN care home offer. If you take a look on our website, you can see that there are comprehensive training documents to support colleagues delivering Teams training in care homes, as well as hints and tips in the use of technology for remote monitoring. In addition to this, there is the medicine optimization program. So some really helpful information around supporting new residents of those who have been recently discharged from hospital. So that's the TCAM approach that you may have heard, and also ensuring that delivering structured medication reviews are undertaken. We wanted at the AHSN just to showcase again some of the work that we have done as a healthy ageing programme. So there's some resources that you can go and access freely, particularly around hydration at home. So some fantastic leaflets and posters that you can give not only to the residents but their visitors, but also the individuals working within the care home setting. I'll just pass over to Faye.
Thanks, Cheryl. Like our colleagues at Wessex AHSN, the Health Innovation Network, which is the South London AHSN, has a really strong healthy ageing programme. And within our healthy ageing programme, we do lots of work to support our local care homes. And one of the things we're most proud of is our Care Home Pioneer programme, which is a leadership programme for care home managers and senior nurses within the care homes. Understandably, this year we've faced some challenges due to the pandemic. And as Cheryl was saying, one of the things we're most proud of is being able to offer this program virtually. We've been able to deliver the program using Zoom, running action learning sets, which is facilitated by Danuta from My Home Life. And I had the opportunity to go to one of the wash-up sessions and hear some of the feedback directly from the care home managers. And overwhelmingly, they told me what a fantastic support system it had been to them throughout what has been a really challenging 12-month period. And lots of them talked about how they wouldn't have been able to kind of get through that period without this program, and how it's allowed them to continue to grow and develop as managers and senior members of the care home. We're about to start a quality improvement aspect of this program to really support the care home managers, develop quality improvement skills, and to implement some of the things that they know will improve the lives of their residents and their staff. So really looking forward to seeing how that develops and to build that into future pioneer programs at the HIM.
Thanks to the team for that presentation. It wasn't easy to think about how we introduce this next part, the impact of the pandemic in relation to quality of life for people in care homes. And we know we can't do justice to the massive impact that it has had. We just put our stuff on hold in the context of everything that was happening to care homes and spent the first few months touching base with people and offering support where we could. Over the last few months, we've started our development programs and other work again, continuing to learn all the time. There will, we hope, continue to be opportunities nationally and locally to look back over this time and for people to learn together. Care homes have been continually responding to an avalanche of policy, guidance, and directives in response to the pandemic. We heard and continue to hear amazing stories every day of courage, continued challenge, and of resilience and creativity. There are so many issues that care homes are being asked to address every day that are directly or indirectly having an impact on collective perceptions about quality. Again, this is just a tiny snapshot of what is currently happening. Each of the headlines on this slide involves many complexities for care homes to consider. How can we make this work well? How and who do we need to collaborate with? Is there something we really need to be courageous about? Set in that context, there are some positive changes and ways of working that have been speeded up or developed to support quality of life over the last year or so in the face of so much uncertainty. And this next section contains some of those. We'd like to start by introducing Blesson Thomas. He can tell you more about himself and what has happened in the care home he works in.
Hi, Tom and Steph. My name is Blesson Thomas. I'm a registered nurse manager for the Heights Nursing Home that's based in High Wycombe, Bucks, under the Fremantle Trust Group. I've been a care home manager since the year 2014. Prior to that, I have worked in different roles in the care home. The last role that I had before I became a care home manager was a deputy nurse manager. And I also practice as an advanced nurse practitioner within the care home service. Since the pandemic started, I'm very proud of the way how my staff has actually responded to the situation. They went through different challenges themselves, but they came out to deliver the best for our residents. I had staff members who had family members who were critically ill, who had number of medical problems, but they stood together and they provided the best care for our residents despite the challenging times we went through. There are several learnings that I have taken from this pandemic. The pandemic has really taught me to identify who our real heroes were, especially domiciliary staff, our household team members, administrative staff, our kitchen staff, the way they had to work creative, the way they had to go extra mile in achieving things for our residents were fantastic. And we had seen this happening so many times in our care homes. The pandemic brought us together and we started working together. We had staff members from different backgrounds, different nationalities, different religious backgrounds. We started sharing what our feelings were, talking to each other of what our challenges were, and what kind of support systems were there in place. The greatest support that staff members had were the mutual support that they got from each other. This pandemic greatly taught me to reflect, take a pause in life, and reflect on my own life. We all live in a very busy environment, going to work, getting things done, coming back home, and it was very, very busy. But actually, this pandemic taught me how important life was. It made me think that how important it is to value time. Each second was valuable, and quick decisions had to be made. You had to put risk assessments in place, address the challenging situations, and that's how this pandemic brought out the real leaders. During this pandemic, we have used technology like never before. We have seen not only us, our residents using technology as well, using Zoom, using FaceTime, chatting, using the mobile phones, smartphones, talking to a doctor on a laptop. I had one of my residents who was 90 years old who even started their own Facebook account so that she could keep in touch with her grandchildren. How fantastic was that? This actually brought use of technology more into care homes. There's been a lot of innovative studies being done, research programs being done into how could we bring more, how could we use technology more in care homes. During this pandemic, we saw networking like never before. We had contacts from Canada, New Zealand, from Australia, and we started learning from each other. They started asking us how our risk assessments were put in place. They started asking how do we manage the difficult situations, and we started asking them questions as well. So we started sharing and learning from each other, and we have made great friends. And I believe that this is going to be more in days to come. The other thing that we learn or reflect back on this pandemic and we can put into action is we became very close to our residents. Our residents and the staff became like family members because the families were not visiting as often. We heard and we have read of so many beautiful stories of staff who've moved into a care home to support the residents there, forgetting their own families. I had residents who used to ring and check if I was okay, how my health was. We had a lot of family members who used to bring gifts, appreciating staff team, who used to write messages, and so on. I also saw there was a lot of innovative ideas that started coming out of how we could engage our residents more. When residents were in isolation, to make sure that they were safe, and to combat depression and isolation and loneliness, we had inter-home quiz competitions. We had inter-home matches taking place on the virtual platform, and it was a great success. And our residents still talk about it even today. The one most challenging situation that I found during this pandemic is the government used to issue guidelines about several aspects that were even applicable to us care home providers. And it used to come in the last minute on a Friday, late in the evenings, and sometimes it was difficult to see how we were going to put this into place. We used to have family members who used to ring us and ask about, we read this in the newspaper, we just saw this as a breaking news. Can we do this? Can we do that? And sometimes we could not translate the way how the government wanted us to implement these things in a short given time. So that is one of the biggest challenges that I faced during this pandemic. The second thing that I faced as the biggest challenge was keeping the staff morale high. There was clap for NHS staff that was taking place, and regularly every week we too used to go out and clap for the staff in the NHS. So my colleagues felt that social care staff were left out. There was a lot of work that was done in care homes, where care staff were also doing their best. And staff many times have come to me and said, Blessing, there's a lot of emphasis on what the hospitals do, but there is little emphasis and little appreciation of what happens in social care setting. So these were the two challenging situations that I found.
Thank you so much, Blessing. Our next presenter is Sheila Sorby. One of the themes of today is developing ideas about quality together, including people who work in care homes. Sheila currently works at Leeds Community Healthcare, and she will tell you more.
Hi Tom, hi Steph, hi everyone. Thanks for inviting me along today. It's great to be part of the day. My name's Sheila Sorby. I am the Assistant Director of Nursing and Clinical Governance at Leeds Community Healthcare. I'm a registered general nurse, have been for 29 years now, and about half of that time has been spent working either in primary care or in community care. I've worked in both clinical roles and clinical governance roles, and a big part of both of those roles has been working in collaboration with care home partners, something I'm really passionate about and therefore really thrilled to be part of today. So first of all, you've acknowledged that a lot's happened and a lot's changed since the pandemic, which it absolutely has. And you've asked, how have I worked with care homes to support quality of life for people who live, die, work in and visit care homes? So much has changed over the last 12 months, with the pandemic itself bringing opportunities for health and social care to work together. So thinking right back to the start of the pandemic, there was some great collaboration, some great engagement and working together around the delivery of the infection control and PPE training. I guess observing that in my current role, it was great to see everyone engaged, passionate, about making it a real success and about improving the life of patients and staff across both health and social care. And I think through that training, it was the start of recognising the immense skill set and experience and knowledge that we have across our social care nursing. And it was a great opportunity to learn about each other, learn about each other's roles, learn about how we all work together, and continue to develop that shared understanding of quality and what quality looked like within a pandemic situation. So in terms of what's changed, one of the real positives within Leeds as well was, despite the pandemic, that we've managed to do some work to continue to raise the profile of social care nursing by involving our social care partners in our local third year nursing student recruitment events. So these are sessions that are delivered within the universities that have always showcased acute care and community care, but less so around social care. And despite the pandemic, this year we've delivered the sessions, we've delivered them virtually, but our social care partners have been an integral part of that. So you've asked me what I am most proud of, and that's a really difficult question because there are so many things in 29 years of nursing that I have immense pride for. But I think the one thing that really springs to mind right now is that within the last 12 months, it has without a shadow of a doubt been the most challenging time for our health and social care staff. And what I have observed through the pandemic is our community colleagues working in a truly integrated way with our social care colleagues. So the example that I'm thinking of is our community matrons basing themselves in the care homes, working alongside as a truly integrated health and social care team, providing exceptional care for patients in unprecedented times. And not only care for patients, but also care for each other. So observing staff working together, sharing experience, sharing learning, sharing expertise, mutual opportunities for reflection, for supervision, for psychological support, and all to make sure that the patients got the best care that they could. So finally, you've asked what I think we can build on for the future. We have an ageing population with increasingly complex health and social care needs who need to receive exceptional care in the right place, at the right time, from the right person, with the right skills, in a compassionate way. So we know that integration and collaboration are the national direction of travel. And whilst before the pandemic, some of that was happening, we were breaking down some boundaries and working better as systems across sectors. Through the pandemic, some of that has also been expedited, but I think it's really important that we don't lose that momentum now, and that we continue to do more of that collaboration, more of that integration. I also think we need to continue to raise the profile of social care nursing. So whether that's through employability sessions at universities, like I've already talked about, or student placements into social care, CPD opportunities, career progression opportunities, so that there's some parity between health and social care. And we need to build on that genuine understanding of each other's roles. So one initiative I was involved with in Leeds has been around Take a Colleague to Work Day, shadowing each other on a day-to-day basis to understand where there's duplication, where we can do things better, where we can do things better together. And I think initiatives like that and some creativity are really important to take us in the direction that we need to do for the future. And finally, leadership development. So a huge part of this is around having the right leaders across the system that can work together in that collaborative way with that shared vision. Social care nursing gets an equal voice and is sat at every table that health is sat at, I think has got to be the future.
Thank you there to Sheila Sorby. Building on what Sheila said, we're now going to hear from Emma Self, who is the Delivery and Policy Lead for Enhanced Health in Care Homes within NHS England. Emma will share her thoughts about how the initiative is working and how it can make a difference.
Hi, Tom and Steph. You've asked me to answer a few questions. So the first question is, tell us who you are, a little bit about what you've done and what you do now. My name's Emma Self. I'm Delivery and Policy Lead for Enhanced Health in Care Homes with the Community Services and Ageing Well team, part of NHS England and Improvements. My background is as a district nurse in Nottingham. I've worked clinically since 1998 in a number of district nurse roles and then more junior managerial through to middle management and senior management, looking after lots of different services like community nursing, tissue viability, continence, stroke, neuro, chronic obstructive pulmonary disease, most of the adult services over the years. Then in 2018, I joined NHS England as community nurse lead and then moved over about 18 months later into the role I'm in now, which is Delivery and Policy Lead for Enhanced Health in Care Homes. So my job is to roll out the Enhanced Health in Care Homes framework across all care homes in England by 2024, a commitment in the long-term plan. The second question is, how did Enhanced Health in Care Homes develop? So back in 2014, the new care models were announced, and with that came 6 care homes vanguards, all looking to do slightly different things with care homes to improve outcomes for care home residents and reduce the number of times people were admitted as an emergency from a care home to secondary care. So they did lots of different things. In some areas they used multidisciplinary teams with primary care and the care homes. In Sutton they trialled something called the Red Bag Scheme. All in all, there were lots of different approaches tried through the 6 vanguards, and in 2016 that culminated in the production of the first Enhanced Health in Care Homes framework, which was the total of all the work that they'd put together in best practice around care homes. That was then started to be rolled out by clinical commissioning groups, but then in 2019 there was a commitment in the long-term plan to roll out the framework across all care homes in England by 2024. And the third question is, through the pandemic, how has Enhanced Health in Care Homes supported quality of life for people who live, die and work in care homes? So there's been a number of different things that have happened throughout the pandemic. the pandemic notwithstanding, it's allowed us to break down a number of barriers that have existed for years between health and social care, and things that would have ordinarily taken months, weeks, or even years to do happened within a number of weeks. For example, the rollout of NHS Mail. We'd got about 10% of care homes using NHS Mail prior to the pandemic. Within weeks, that shot up to beyond 60%, just by allowing access to take place slightly differently and removing some of those barriers which had existed before. Also, the rollout of the framework continued despite the pandemic. So the really key elements of things like having a named GP, a named clinical lead for every care homes being aligned to primary care networks, and then having the weekly home round or check-in taking place. All of those have started throughout the pandemic and are proving really beneficial in starting to really coordinate care for those residents in a personalised care and support planning way. And the last question is, how do you want it to support quality of life going forwards? So my vision is that every resident living in a care home has the same access to health and care services as somebody would who is living in their own home. So it shouldn't matter that they're living in a care home. They should still be able to access a dentist. They should still have access to hydration and nutrition support. All of the things that if I were living in my own home, I would have access to through my health and social care system. And that it shouldn't matter where a person lives, that care should be absolutely equitable. And that we support the health and care workforce to deliver that care. At the moment, it's far too secular and organisational, the way things are divided up. It should be a singular workforce that's delivering that care and are supported to deliver that. So that's my vision for the future. Thank you.
Thanks so much. Yeah, at this point in the webinar, having shared examples of some of the great efforts that are out there to develop quality in care homes, it's now time to look at how we can build upon this positive foundation. We need to ask ourselves, how can we support care homes to deliver to their potential? What would this look like? How might we build on their skills, creativity, and expertise? Also, how can we quickly galvanize on the new goodwill from the community that's been shown to care homes before the risk of indifference returns? Might we imagine a world where care homes do more than support quality of life for those within the homes? Could they be places of reflection, of connection for all of us? Could care homes in the future be reaching out more to support those living alone within the community who perhaps have a poorer quality of life than the residents? We think that with long-term investment in the extraordinary managers and staff who have shown us their big hearts over the last 12 months, their bravery, ingenuity, their courage, that we can build on the best of what good practice looks like, so that care homes can be truly cherished as a vital and relevant part of our community in the future. So on that note, I am delighted that Deborah Sturdy, Chief Nurse for Adult Social Care and a valued colleague for many years for My Home Life, has agreed to offer her views on the future. And hopefully Deborah's there. Are you, Deborah?
I am.
Ah, hello. You're named as Justin Newell.
Oh, is it?
Not to worry. Over to you, Deborah.
So thank you very much, Tom and Steph, and thanks to everybody who's presented this morning. That was really energising for me and very exciting to hear the work that's gone on across those particular homes. But I know that everybody has worked incredibly hard this year. It's been like no other. And beyond that 12 months, actually, we're now into what, month 14, or feels like longer than that. So a huge thank you for everything that everybody's done. And it's really interesting because I was very much part of My Home Life. I was working at the Department of Health at that time. I remember its kind of its genesis, its kind of growth. So it's fantastic to see how it's grown, developed, embraced and changed over the years. So really pleased to be here this morning. I think that just picking up on some of the things that have been said around, particularly around workforce, to imagine a new world, we can't always do what we've always done. We have to look at our workforce. Our workforce are critical in this. And I just feel that we have to make social care, nursing care, whatever job we want to do, not a second-rate option, but a first-rate choice. And we need to start talking about careers in social care, not jobs in social care. So I think we have to change our language. And I think as as a sector have to stand tall and be proud of the phenomenal work that's gone on. I think to that end that we need to, as part of the social care reform, we're going to be looking at workforce reform as part of that, but we have to have this proper skills and knowledge framework. We have to offer that career path. We have to tell our stories, the fantastic stories you've told today about this is a pathway, and there are so many places that you can stop off and do something. So, you know, we've heard from activity workers, we've heard from you know, registered nurses, we've heard about advanced practice that's going on. There are all these possibilities, and we need to be articulating that much clearer and much better, so that people can come and see and have a glimpse into the world that we all love to work in. So I think workforce going forward is absolutely critical. And like I say, what we've always done is not going to sustain us going forward. So I was asked to kind of imagine a care home of the future. So these are kind of quite personal views, and ones that come from, you know, a huge amount of experience now, having traversed a career across both health and social care. So for me, that future has got to be that care home has to be central to the community. I think the changes that we've seen in working throughout the last year, in the wider workforce around people working at home, we're going to have a lot of retail space, a lot of office space that's not going to be used. How can we turn those into, you know, potentially care homes in the middle of your high street? So I think we have to think about, you know, moving care homes from the edge to the absolute centre of our communities. And I think that the choices that we, you know, we talk about choice all the time, and, you know, and I've been guilty about this over the years, but it's about, it really is getting us all to shift to that my choice. So my choice is my choice. It might not be yours, but it's what I want. And it was back to Sheila's point about we have to change the workforce of the future. So we have to get those undergraduate health professionals, and I don't just mean nursing, I think our medical students, our therapy students, to actually experience social care, so that when they become the orthopaedic surgeon of the future, or the A&E doctor, or the cancer nurse specialist, they really understand the context of where people come from, and then will be able to appreciate and value that when people want to make choices, it really is their choice. I think we have to really grapple with this issue about supporting people, not being done unto. So for me, if I was in that space of living in my community, I want to be supported to remain part of that community. I don't know, I want to be able to go to Marks and Spencer's coffee shop that's next door to the care home I work in for my coffee. I don't want it served to me in my room. I want to be able to, I don't know, go to a church service if I want to, because the church is just across the road from where I'm actually living. I think we need to, you know, I think it's what Emma was saying, we need to embed into a system which responds to me. And that equity issue is absolutely critical, that we have that health offer that extends to everybody, regardless of where they're living and regardless which bit of the country that's in. I want to be sociable outside that home and not in it. So phenomenal. I mean, the stuff that was talked about, you know, about getting Daniel O'Donnell to send that message in to, you know, bring China, you know, I love traveling, so to bring China to that person. But I think that's fantastic work. But actually being part of that sociable scene outside the home is really, really important too. And I think I want that space, if I'm living in that environment, to be somewhere where my friends, my family want to come. And I want to be, you know, I want to, I think we should actually have almost like one of these dating services, match people, so that when you're in that cluster living in your home, that person in the room next to you has something in common with you. And I think we need to just think a bit more imaginatively about how we create some of those interest groups, those friendship groups, and enable people to have relationships within those homes. So I think those shared spaces need to be with friends, not with you know, other residents, but they are my friends. And I know some people, you know, talk about families, but I think friendship's really important too. Next slide, please. I think that we have to, and we're starting to see this in the way that care homes are being built, but small size units. I think that more domestic feel to things is what people are going to aspire to. I think we're, you know, that next generation is going to want something very different than what's on offer at the moment. And I think people will, you know, will really value that. So again, back to, you know, if I'm in a unit of 6, 8 people, I want it to be people that I actually quite like. So how do you, like say, matching those interests together is really, really important. And I think we can't underestimate technology. Every 18 months, technology changes. So technology is constantly evolving around us. But I think we need to use the technology which facilitates and underpins, not substitutes for the human touch. So I think there's a fine line that we all need to just keep conscious of. I think technology is amazing. You know, the fact that you can go to the toilet and it's done your urinalysis, you know, how incredible is that? And I just see that having this kind of data bank of my information, my dashboard that flashes up on my iPad in my room, so I can see what's happening to me. I can see the fluctuating changes. If I choose to, I might not choose it, but I would personally want to see that dashboard that's about me. How can we make that accessible for the person and the receipt of care, as well as those caring for them? And I think we need to, like I say, but we need to remember the human touch, and let's not substitute technology for that. Robots are great, but in their place. I think that whole offer has to be much more flexible. I might choose to live in my own home, but the care home down the road, because it's such a great space to be in, I might just, if I'm not feeling very well, want to book myself in for a weekend. I might want to book in, you know, it might be that my family want to go out for an evening and I'm needing more support, that I can just pop in there for a night. It might be that I go and have, you know, surgery and I just need somewhere to go and recuperate for a while. And I might do that as an individual, not just through, you know, through contracts, through local authority. So I think flexibility about what we offer in those spaces is, you know, is going to become more and more important. And I think the other thing, you know, just thinking again about what Emma was saying about the Enhanced Health in Care Home programme, it just makes me think about how the care home of the future is going to be so bedded into the community that why can't we think about, you know, the NHS commissioning services within that locality, you know, urban, rural, wherever, just that accessible space. Why can't we be commissioning care homes to be providing aspects of healthcare? So again, I think we just need to be thinking much more creatively than what we offer at the moment. And I want somewhere that's worth visiting me. So it's a place of fun. So it is somewhere where my friends and my family can come, that, you know, the phenomenal activities that go on, that they can be included in. So I want it to be a fun place, and I want it to be about, you know, about what the things that I like to do. So I think that we are moving towards that, but I think we've got a long way to go about that real, true inclusivity of families. And I think some people do it exceptionally well, but I think we can do more around that. And like I say, I want to be in the middle of a community and not on, you know, my community, not on its edge. So I think that we really do have to think about where we are creating those care homes of the future, where that space is. That kind of physical closeness to other people, I think, will help us dispel the kind of myths around social care. And it was back to the point about, you know, we're clapping for the NHS. It did transform into clapping for carers, but actually, and one of the things that we have to capitalise after this, you know, incredible, pandemic, and I think one of the positives we have to take from that is, you know, the whole of the country has probably had a greater insight into the work of health and social care professionals, and, you know, very much social care professionals in this last year. And we have to capitalise on that, inviting our communities in, you know, when we can safely do that, actually, you know, bring them in as part of that community and capitalise on their support, really. And that kind of volunteering going forward. How do we make sure that we retain those volunteers and retain those people who show this real interest in their communities? And I think we have to, you know, we have to move to people having total control and facilitated choices. So, you know, again, it's very much, I know, you know, it's something that my home life have been fantastic about that relationship-centered care, that real, you know, that real person at the center. So I think we've done phenomenally well there. You know, when you think of 15 years of my home life, all the things that you've talked about this morning are moving us forward continuously. I think there are huge challenges now about getting this workforce right and making this a really a place where people want to come and be that first-rate choice for your career.
Brilliant, Deborah. Thank you so much. And I wish we had a bit more time to listen to your visions. Really, really good. We are running out of time, but we have got some space now for some questions, and there is a button, I think, on your Zoom which says Q&A. It's a Q&A function, so you've got a chance to ask questions of the individuals that did the videos. We've got Angela Boxall from Majestic Air here representing them. We've also got Sheila, Johnny, Jeff, Cheryl, and Emma, as well as Deborah, of course. We don't have much time. We'll probably, if you can stay with us, then it'd be great if you could stay for about 10 minutes or so, but not to worry, because actually we are planning to do another one of these, but a more of an informal gathering on the 10th of June at 11 o'clock, and you will receive an email, and that's really about just keeping the conversation going, much more informal, two-way conversation. So with that in mind, please do pop your questions in, your thoughts, ideas. If you've got a particular question for us, someone you heard speak, then please name them when you type. And at this point in time, I'm going to pass to Steph, who can facilitate the questions as they come in.
Thanks, Tom, and thank you to everybody who's made a contribution to today. I'm going to hope that Amy can help me with this a little bit as well. There are some questions coming in to the Q&A box. So I'm going to open them up and see what happens. So our first question is from Samaya in Lancashire. She said, small in unit size we would agree with, but does need some regulation and planning authorities to be on board. How can one registered manager oversee responsibility? We need to think about that. There's not another question, but just a lovely comment, so I'll leave that. I'm just going to read a couple of these out. What's the panel's view on the main barriers that prevents focusing on improving quality of care in a meaningful way? And how do we ensure that sustainability, especially in quality, is linked to a willingness to invest resources by commissioners? I'm going to ask the panel to comment, to think about that one, and I'll ask you in a minute. Another question from Andrew, how do you see residential care providers responding to the challenge of low occupancy levels created the local authority stance on home first? One for Emma, please can you share your contact details? So I'm going to ask the panel to sort of think about that real issue about the main barriers that prevent focusing on improving quality of cares in a meaningful way. And then the second one, again, an open sort of question to all the panel. How do you see residential care providers responding to the challenge of low occupancy levels at first? And panel members, please do put your videos on if you can. And Deborah, obviously I'm maybe asking you, but I'd be really interested in other panels members on answers on both of those questions, if you could put your hands up.
So do you want me to start, Steph?
That'd be great.
So I think that, you know, there's a lot of discussion at the moment about social care reform. I think that quality has got to drive, you know, the kind of the commissioning agenda. And I think, you know, local authorities believe in that too. So, you know, it's something that's been considered and thought through at the moment. I know the Minister for Care Services, Helen Whatley, is very keen on the whole, the issue about how we improve quality. And I have a one-to-one meeting with her, quite recent in post, but we talk a lot about quality, and they're quite informal chats we have, and about how can we improve quality. But I completely appreciate that needs to be, that has to have the funding that comes behind it. But quality is not just about money too. I think it is about, some of the phenomenal examples we've heard this morning about people's attitudes, people's creativity, people's kind of solution focused approaches to making care, care experiences so positive and so individual. So I think it's a mixture of money, but I think it's also about some of that kind of local leadership as well.
Does anybody else on the panel have a view about what gets in the way in relation?
Yes, certainly, Steph. I've had my hand up. I don't know if you can't see it. So yes, absolutely. I'd very much like to address Shiv's question about the meaningful response, and also to a degree Samaya's point about regulators and planning authorities, because I think for me the answer lies in a whole system approach. If it is, there'll always be opportunity to deliver small quality improvement projects. And I apologise to all the people listening about the very fast whiz through we did about Restore 2. It wasn't meant as a teaching session on the deterioration tool, but more an example of what's possible when working together, and how the project develops in tandem with an organisation like the Patient Safety Collaborative and the various care homes and provider organisations involved. And that, I think, is a great model. And I think we're seeing that what Deborah was talking about in practice now. We've got the Enhanced Health in Care Home initiative. That's in its second phase, as it were. The first phase was tested around the country and got some enormous benefits. So this second one is being promoted down the commissioning route. So for those who don't know, maybe the CCGs have been required to deliver it. They've by and large passed that commission on to the primary care networks and the local multidisciplinary teams. Responsibility has been given to them. So we're looking at how to implement the Enhanced Health and Care Home framework at local levels with the local multidisciplinary teams. And at the same time, we've been commissioned by them to provide regional improvement. So we can work with the Enhanced Health and Care Home leads at NHS regional offices, but we can also work with the CCGs and the primary care networks. And also we can work directly with the care homes or all provider organisations. Sorry, I keep mentioning care homes, but I mean all care sector providers.
Thanks, Jeff. That's really helpful. And Emma and Sheila, you've both got your hands up.
Yeah, thanks, Steph, and apologies. I'm on my phone today. Couldn't get on my laptop. So to answer what gets in the way. So a couple of things throughout the pandemic, or certainly the beginning, we were, when I say we, I mean health services were very guilty of producing a lot of guidance, which was necessary, but very much our care sector leads kindly told us we were essentially lobbying stuff over the wall of the care home, which wasn't very supportive. So throughout the year, we've really moved to a point of collaboration and co-production, which is enormously helpful, because that's absolutely the way forward, that we do this together and not sort of in spite of each other, that it's co-produced from the ground up. And one of the things we produced as part of that work was just to kind of scan around and look at what we were doing in totality across health and care in and around care homes. And just from the Aging Well programme alone, we came up with about 20 different things that were going into care homes. And that's not including all the other parts of the long-term plan and different programmes. So as a care home manager, they're faced with not just obviously CQC regulations and things they need to do to satisfy CQC and their proprietors, and obviously to keep their residents and staff safe. But then, you know, this whole sea of confusion of things that they may or should or might need to do, that isn't particularly helpful to access. So in terms of, you know, what gets in the way of improving quality, that does. So what we're looking to do over the next sort of weeks and months is to really coordinate our efforts so that there's almost like a single point in, so that, you know, we can really make that clear, what's available, what's needed, and what can help.
That would be really helpful. Sheila? And then there's one other question in the chat that I'd like people to answer before we have to stop. But Sheila, what were you going to say?
Yeah, I'll make it really quick. Thanks, Steph. So I agree with everything that's been said. I think it's around that system. We need to think of quality in terms of experience, safety and effectiveness. And it's how do we make sure that that's measured around a person, and as a system level, like everybody's just said, rather than sort of siloed elements. So would completely agree with everything that's just been said.
We do only have time for one more question, which is really sad. But as Tom said, we will be sending a quick survey out at the end of today and an invite to a further conversation. But Emma's asked, how do you think that we can respond to low staff morale within care homes at the moment? Anybody any thoughts on that? Angela, it'd be lovely to hear from you. Angela's from Majesticare. It was her team that invited Danny and brought China into the world.
Yeah, we should always travel, I think. Relationships, and I think, you know, going back to what sort of Deborah said, and it sort of links into all of the questions this morning, is that we can only improve quality by relationships, and it's not all about money. And I also think that is what actually, you know, will keep us going through the staff morale as well, by listening to people, by sharing experiences with people, and by being part of a team. And that includes sort of, you know, what Emma was saying. So the team isn't just in the care home anymore. The team is so much wider than that now. And you know, we've built up relationships with lots of different multidisciplinary people over the last sort of 12 months, more than ever. And those relationships are crucial, because actually, you know, it's a bit of a cliche, but together we can achieve more. And by taking every single one of our teams on that journey with us, that's what keeps morale. I think if they feel part of a team, if they feel listened to, they feel valued. And yes, money helps. We're not going to deny it. But I agree with Deborah. You know, it's the little things that matter. We did some surveys about what mattered to our team. You know, what we did for them over the pandemic, and the highest scoring thing was a handwritten thank you card, which, okay, took a little bit of time, but when it landed on their doorstep, they appreciated that time that it had taken. Yeah, for me, it's the personal touch, it's relationships, it's continuing to grow those relationships, about knowing each other. And it takes me back to the video right at the beginning of the webinar, which has been fabulous, by the way, which is Alison. And Alison said, you know, the relationships between the residents and the staff, that has to be there to create any good community, good atmosphere, and good quality care in any care home. And Alison lives in a care home, so I think Alison should know. You know, and that's what I've got to say on that one. But yeah, really, really interesting. And it's been so difficult for the teams in health and social care over the last 12 months. In total awe of the amazing job that everybody's done. I would clap every Thursday if I could, but you know, the clapping has to stop. But let's just hope that the goodwill and doesn't stop for the staff that work within health and social care, because they thoroughly deserve it.
Thank you, Angela. And I'm going to stop us there, because we've run out of time, and actually I can't think of a better way in which to finish, unless has anybody got one final nugget that they want people to take away with them? Our aim was that by the end of today you'd heard something, one top tip that you could take away. Jeff, I know you've got your hand up. Is it a tiny nugget?
No, I was going to respond to the question about what we can do for our staff, but no, I accept. Appreciate your point about being out of time.
Thank you. Thanks to everybody who's joined us today. We had over 150 people, which is just amazing. There's less of you now, but that's our responsibility for going over time. And thank you to this amazing group of people, our panelists who've helped contribute to today in so many different ways. And we hope you have a great rest of the day, and the sun's come out in Hull. So what a fabulous day way to finish. Thank you, everybody, and goodbye.